Manuel, Leo.
Thank you.
Manolo.
Thank you.
Leo.
Okay. Thank you very much for these thought-provoking presentations. You know, one of the things that I feel when I read these Torch and other New England or Lancet papers that they are triple-blinded, meaning they are double-blinded and also the reader is blinded. So, you know, you just don't know what the population is. So it's a triple-blinded. And this, you know, the Torch is a perfect example of, I almost would say, cheating, because when you split, I mean, these studies take COPD, meaning COPD goal 2, 3, and 4, all at the age of 60 or more, meaning there are totally different patients, totally different risk factors. I mean, the goal 2 is never a severe disease, but enters in there. So what do we find? Jerkins found in the post-hoc analysis of this, and you mentioned about what happened in exacerbations, in mortality. And this is something that I really would like somebody to explain to me. The real prevention of mortality in the Torch study is in goal 2. According to the data of the post-hoc analysis of Jerkins. I asked her if she could explain that to me, and she said that she just couldn't, but that's the fact, that's what she found. And this gets to me to the data that was presented by Soler and Catalunya, talking about the real thing is that the mortality based on exacerbations that you presented, that you know, we cannot really put it one-on-one together. I mean, we are not, you know, necessarily the mortality of exacerbations doesn't mean necessarily that the drugs are preventing exacerbations in people who died, because they are preventing exacerbations in 2s and 3s. So, you know, this is, we cannot really swallow this data like this, and I wonder if we are doing something better in order to really going into the real effect of the drugs that seems to be in an earlier COPD years, and certainly not in the late COPD years.
Okay, shall I start first, as I suppose yes. You're correct on this, and I think one of the problems is that Torch was started, late 90s. So our views on COPD were very, very different. And, you know, the patients who were recruited were under 50, well, they were under 60, but they were fairly severe patients. I agree with the finding that goal 2 patients, that the mortality signal is strong, because I believe you're probably reducing death from cardiovascular disease. So if you're reducing death from cardiovascular disease and COPD, how do you do it? I think you're doing it through exacerbation reduction. Others think it's through a reduction of inflammation, reduction of CRP. I think exacerbations are very closely linked to cardiovascular comorbidity. So I think the observation is absolutely right that it's the goal, that if you want to do a mortality study, you go after goal 2. You go after patients with cardiovascular disease. The problem is when you get to under 50% predicted, the patients with severe cardiovascular disease in the past, a lot of them have died. But there again, our management of cardiovascular disease is better. So, and I think the second point of your thing is really about phenotyping, isn't it? And we're now much more careful about phenotyping, though how far forward we've gone with phenotyping, I'm not sure. I did say to you that, for instance, I think the 2 or more frequent exacerbator, to me, that's nonsense. You know, it's a gradual scale, at which point you become a frequent exacerbator, I think is difficult. As Nick showed, these people do change. So, Nick, do you want to add to that? Or?
No, I think that's. I think that phenotyping is definitely the issue, but I'm not sure that we know now how to phenotype. I mean, we all believe that it's an issue, but and I think that's the one of the big advantages of the studies that are ongoing now, the Summit trial, for example, with the cardiovascular issue and so on. But that patients are going to be much better characterized in the studies, so it will allow us afterwards to know who responds. I hope to know who responds and why. Who are those who will respond to one approach rather than the other? But, well, we don't have the results yet. But.
If I can have a comment, just 2 words. The problem, you see, that we all agree that the type 2 is the goal 2 is the one. The problem is that we don't see goal 2s.
Yeah.
That's the problem, you see. So they are good for the studies, but then we don't see them as pneumologists.
Well, can I answer that even more? You're absolutely right. So I took on a research fellow specifically to do studies in gold 2 exacerbations. So if you ask me what happens to an exacerbation in patients with an FEV1 above 60%, the only person who knows is Marina, because you, in your biopsy study, you had some of these patients. But are they more susceptible, less susceptible to viral infections? What's the viral loads, bacterial load? So I took this guy on, and yesterday one of the other reasons I was late yesterday, I was moving, and then he said, look, I can't find these patients. And you're absolutely correct. These patients, a lot of them I think we've got to stand outside supermarkets and do spirometry to find these patients. Perhaps in the UK, not Marks and Spencers and Waitrose, but in the UK, in the cheaper supermarkets to find these people. That's what I said.
Now, I have 1 comment and 3 questions, short. The comment is what I anticipated to you earlier on. There is a lot of pressure now, internet yesterday, maximize bronchodilation. And at some time I'd like to have your opinion. From David Price, for instance. And the questions are the following. Is it any evidence on the primary outcome of the studies performed that there is a difference in the population targeted between the long-acting bronchodilator and the combination, on the primary outcome? The second question is any evidence that there is a difference, meaning a patient-related outcome, not FEV1, patient-related outcome. The second one is between the single bronchodilator and the combined bronchodilator, apart again from FEV1, on patient-related outcome. And the third, I think that you missed an opportunity, Nicolas, in defending your point. There is a post-hoc analysis of the torch that suggests, paradoxically, that the effect on mortality may actually be related to the salmeterol rather than... So the question is that the need for a non-sponsored, an independent study to look at the effect of bronchodilator by themselves in that kind of population on mortality?
Yeah, definitely. That's what I showed at the end. I believe that there is... I think it was Sami Suissa who did this 2x2 post-hoc analysis, and so this is very interesting, and it goes very well with the data on severe exacerbations that I showed. Sorry, not did, because you have the same kind of effect, which is mainly on bronchodilators for mortality if you follow this paper, and severe exacerbation, and it goes well together. So that's one thing. Regarding the maximizing bronchodilation, I think it's quite difficult to know. We probably can't go higher than a given degree of bronchodilation between once we've bronchodilated the patient. I mean, they can't improve. They have emphysema, which is blocking, you might say, in some patients. So again, it's a question of phenotyping. And probably the consequences of maximal bronchodilations will not be the same from one patient to another, depending of his underlying phenotype, meaning more bronchial, more emphysema, for example. So I don't know, Visha, what
Well, the evidence is that there is, and you know, Leo, you probably and Marina know it better than I do. There is evidence that a LABA and LAMA can have some synergistic action, though we've not seen this. I don't think we've seen that if you put a LABA and a LAMA together, you get an increase. You get an increased effect as such. I think there is one review that Paul Jones is involved in that shows the greater degree of bronchodilation, the more you see effects on outcomes. Now, I don't think it is just on primary outcomes. That review is very difficult reading. I've actually tried to have a look at it, and I don't know if I have difficulty. I'm usually quite good at papers. What about maximal bronchodilation? My own view is that if you want to maximally, you probably have to go to different classes. So you have a little bit from an anti-inflammatory, then you have your LABA and your LAMA. And you know, Clive Page will say, well, you know, go to an inhaled PD3 inhibitor. So, you know, they certainly showed in the Lancet Respiratory, I wrote the editorial a few months ago, that if you take an inhaled PD3 inhibitor, you can get quite a good degree of bronchodilation. Of course, they've got to try the PD3 on top of everything else. So I think the answer is we don't know what is maximal bronchodilation. Or can we do it with LABA-LAMAs, or do we need other treatments to help us do it?
But I think one important thing is that when you look at the patient-reported outcomes and the additive effect or synergistic, or well, it's not synergistic at all, it's less than additive, the effect on patient-reported outcomes. So the additional effect of adding one to the other is much less from a clinical perspective than from a pharmacological perspective. And that's probably due to some ceiling effect. I mean,
I tell you what my concern is. My concern is that on one side, I think there is rationale to lower blood pressure, glycemia, hemoglobin, glycosylated hemoglobin, because you know that you prevent long-term outcomes, stroke, myocardial infarction. I don't think there is any evidence that maximizing bronchodilation is affecting mortality or any major outcome. That's one. The second one is a general concern. There is strong evidence that maximizing the control of glycemia is dangerous. Maximizing the control of pressure is dangerous. Lowering blood pressure in people with stroke may be dangerous. So before recommending, you know, an effect on a biomarker without knowing what is the effect on the patient-related outcome, I think is dangerous. I think it's misleading. And I finish. The second, I'm concerned about all this flow of new compounds, of the increasing number of people that I can see with combination of LABA and ICS plus an additional LABA.
And plus a combination of LABA-LAMA. Well, I think there's two things. Is perhaps, you know, your last comment is about that's a real problem. So patients are on a LABA-ICS, along comes the LABA-LAMA, and they'll be on double LABA. And I think that is a real concern because certainly in the UK, most of COPD is managed in primary care, and that is something that is a real problem. I think FEV1 is. We know that a very low sugar is not good for you, but we know that the higher the FEV1, the better should be both the mortality and the cardiovascular outcomes. So there's a stronger case for studying improvements in FEV1. My slight concern is which patients can you really get good improvements in FEV1? We know that reversibility is very variable. So I think we were told, if you remember 10 years ago by Peter Calverley, don't bother with reversibility. Now we are looking, because after all, this is reversibility, isn't it? You put somebody on a LABA-LAMA and you get a nice change in FEV1. So I think we've got to rethink what we mean. And you know, is vital capacity a better measure? Is FEV1 even the best measure? So we need to talk about this.
Okay. Now I think